Well, what about the inferior vena cava with a mechanical breath? The physiology is a little bit muddied when assessing the inferior vena cava. The reason is that the ambient pressure of the inferior vena cava is no longer the pleural pressure, it's the abdominal pressure. Remember the IVC, there is really no intrathoracic IVC in humans. There are in dogs, but essentially as soon as the IVC crosses the diaphragm, it goes directly into the right atrium. So it's kind of a potential vessel, whereas the IVC that we're looking at with an ultrasound is actually intra-abdominal. This is less of a problem when a patient is heavily sedated and potentially paralyzed, as abdominal pressure increases consistently with each inspiration. And the change in abdominal pressure is a function of the change in abdominal volume with inspiration as the diaphragm descends, and abdominal compliance. Okay. Excuse me. Therefore, during a mechanical breath, the central venous pressure or right atrial pressure is increased relative to the increase in abdominal pressure. So now I've modified my diagram a little bit more. And so now you can sort of think of this as the inferior vena cava. This is your mean systemic pressure driving blood back to the right atrium. And then this is the outflow of the thorax. So this short space here from the right atrium to out of the thorax, this would represent everything in between. So that would be the right ventricle, pulmonary vascular bed, left atrium, left ventricle, aorta, everything right here, blood going out of the thorax. So during a mechanical breath, pleural pressure goes up. Remember, ventilator delivers volume to the airways. That increases your airway pressure. That pushes the lungs open. The lungs push against the chest wall in the passive patient. And that increases your pleural pressure as the lungs push out against the chest wall. We don't ever measure this, but this is what we would see. Because the right atrium is intrathoracic, it tracks up with the increase in intrathoracic or pleural pressure. And this is what we would see, and we see this frequently when we put a triple lumen in or a pulmonary artery catheter and we measure the increase in right atrial pressure. What we don't ever measure is the increase in pleural pressure, and if we did, we'd see that actually the increase in pressure of the right atrium is not quite as high as the increase in pleural pressure, and we talked about why that was in the previous slide. Okay. With the breath, there's also a descent of the diaphragm, and abdominal pressure goes up, but it goes up not quite as much as the increase in right atrial pressure, because less of that intrathoracic pressure is distributed to the abdomen. Simultaneously, there's a decrease in venous return because of the increase in upstream pressure while abdominal pressure is increasing. So what does that do? Well, that increases the pressure in the right atrium and very distal IVC relative to abdominal pressure. So remember the IVC, as soon as it crosses the diaphragm, it's essentially in the right atrium. So as the right atrium goes up, the pressure in the IVC goes up relative to the increase in abdominal pressure. So this increase in right atrial pressure relative to the increase in abdominal pressure, this creates a bit of a distending pressure, and the IVC actually dilates during a mechanical inspiration in the patient who's fully passive and not generating any negative intrathoracic pressure. So what was found is that actually IVC dilation with mechanical inspiration is a good predictor of volume responsiveness. It's the same physiology. Now your transmural pressure is the right atrial pressure less your abdominal pressure. So during the mechanical inspiration, the increase in CVP relative to the increase in abdominal pressure is increased. So the transmural pressure of the inferior vena cava is actually increased in the fully passive patient. So now we're moving rightwards on the transmural pressure graph. So your CVP, the right atrial pressure, is going up relative to the increase in abdominal pressure in the fully passive patient. So if the patient is on this portion of the IVC, IVC diameter transmural pressure relationship, there's going to be minimal dilation, and this patient is not going to be preload responsive. Whereas if the patient does have a large increase in IVC diameter with mechanical inspiration, then this patient will have dilation, and this patient will be judged to be preload responsive, and indeed that's what's been seen. So in the studies of both SVC collapse and IVC dilation during mechanical ventilation, there were consistent changes in intrathoracic pressure. Again, like pulse pressure variation, the reason is that the patients were sedated and paralyzed and receiving a constant volume-limited mode of mechanical ventilation. Thus, for reasons similar to pulse pressure and stroke volume variation described in the previous sections of this chapter, the parameters derived for volume responsiveness are context-specific. Deviation from the physiological constraints under which the diagnostic parameters were defined will alter said diagnostic parameters. So imagine a patient who is heavily sedated and fully passive with the ventilator. The patient has both a transesophageal and transthoracic assessment of his vena cava. Consider that the SVC fails to collapse and the IVC fails to dilate during inspiration. Both parameters therefore suggest a lack of volume responsiveness. So let's, for argument's sake, say this patient is not volume responsive based on this data. Now imagine the patient is lightened from sedation and begins to generate respiratory efforts, both inspiratory and expiratory. So now consider the vena cava pressure-volume relationship. During the passive mechanical inspiration, the increase in CVP relative to the increase in the abdominal pressure is increased. This patient is not volume responsive. Okay, so that's what I just explained in this patient. The CVP is going up with the mechanical inspiration. The abdominal pressure is going up to a lesser extent. There's an increase in the trans-mural pressure, but the patient does not have a change in their inferior vena cava diameter. So this patient is volume not responsive. Now his sedation is lightened and the patient begins spontaneous inspiration. So now we've changed the physiological context, and you can no longer apply the diagnostic parameters that were derived from the patient who was completely paralyzed and sedated with the ventilator to this patient who's generating inspiratory and expiratory efforts. So this patient now who's dropping their inspiration, or dropping their intrathoracic pressure with inspiration, is now going to drop their CVP with inspiration and increase their abdominal pressure as they contract the diaphragm and compress the abdominal contents. Their abdominal pressure is going to go up. So pressure in the vessel going down, pressure outside the vessel going up, and now transmural pressure is going down. So this patient, depending on really multiple factors, one of them being how active they are in inspiring, this patient could have a pretty significant collapse in their IVC. But what I just told you was this patient is not volume responsive. So the basics of functional hemodynamic monitoring is that there's some stress applied to your cardiovascular system. And in terms of pulse pressure variation, stroke volume variation, aortic flow output variation, and even changes in vena cava diameter. These are kind of classic things that we're assessing with functional hemodynamic monitoring. We're measuring that response, those responses that I just mentioned, in the context of a stress. And the stress is invariably a change in the intrathoracic pressure. So that change in the intrathoracic pressure hits your cardiovascular system, and that's the response. And what we look at is stroke volume variation, and there's a whole bunch of different ways to measure stroke volume variation. For example, a surrogate of stroke volume variation is systolic pressure variation, pulse pressure variation, the change in the velocity time integral out of the aortic outflow tract. Aortic pulse contour analysis is another surrogate of stroke volume variation. So those are all sorts of those are all basically different measures of LV stroke volume variation. And then that's sort of like an arterial side-based assay. And then you have the venous side assays, which is the change in the vena cava diameter. And I'm going to talk about each of these in turn through this lecture. And as I mentioned, it's sort of this pharmacology relationship. You want the stress or the dose to be standardized, and if you start having changes in your stress or your dose, then changes in the response, you don't know if it's something that's inherent to the system itself or if it's inherent to the stress. And that's what I just said. So this is an example of functional hemodynamic monitoring. So what we do is we're going to stress this system, and the response is we're trying to assay whether or not your venous return curve is intersecting the cardiac function curve on its ascending portion. We want to know that it's on the ascending portion because then we'll know whether or not the patient will respond to a fluid challenge. So as we mentioned in Chapter 2, the x-intercept of the cardiac response curve is actually intrathoracic pressure. Again, this is right atrial pressure on the x-axis and blood flow on the y-axis, and this line here marks atmospheric pressure, subatmospheric, supraatmospheric. And again, if you were to arrest the circulation and uncouple venous return, and you measured the pressure in the heart at zero blood flow, you would essentially measure the pleural pressure or the intrathoracic pressure. And bear in mind, throughout all of my lectures, for simplicity, you can use pleural pressure and intrathoracic pressure interchangeably. Okay, so the stress is you give a mechanical breath. The patient is completely passive or and potentially paralyzed, and therefore the change in intrathoracic pressure is a function only of tidal volume and chest wall compliance. The intrathoracic pressure rises, okay? Your cardiac output drops as a function of the increase in intrathoracic pressure on the right side of your heart, and you measure that a few beats later as a decrease in your left ventricular stroke volume or pulse pressure. And you say, well, that pulse pressure variation is therefore a marker of the patient's right heart being on the ascending portion of their Frank-Starling relationship, and therefore this patient will respond to a fluid bolus. By contrast, if you took another patient who's now on the flat portion of their Frank-Starling relationship and you apply the same stress, so you can see that blue arrow is moving to the right to the same degree, but now you can see there is essentially no change in the forward flow from the right heart. With this stress, the same stress, this patient will not have the same amount of left ventricular output variation, stroke volume variation, pulse pressure variation, and this patient will be deemed to be volume non-responsive. Okay, so you can see here that this idea of preload is not necessarily equivalent to preload responsiveness. These patients have different preloads. Certainly the initial patient had a lower preload than the second patient, but the fact that in response to a cardiovascular stress, there was no change in the forward flow, this patient is not preload responsive. This patient is volume unresponsive. So the responses to the cardiorespiratory stressors are commonly evaluated, as I've mentioned, both on the venous side, for example, changes in the IVC caliber, which I'll talk about at the end of the second half of this lecture, and on the arterial side of the heart, that stroke volume variation and its many surrogates, as I mentioned. A couple of points. These tests of cardiac function were derived under italicized very specific conditions. So these are highly standardized stressors or highly standardized doses that are being applied to the cardiovascular system. And once you start deviating from those conditions, the responses that the cardiovascular system may have may not be reflecting volume responsiveness, but rather just changes in the stressors applied. And that the tests will then carry varying sensitivities and specificities. Recall, like any diagnostic test, the test is meant to alter your pretest probability. So if your pretest probability for volume responsiveness is very low, so a patient who comes in with an EF of 20%, who's anasarchic with ascites, is cool and clamped down, and you look at their pulse pressure variation and there's ample pulse pressure variation, well, it's probably the patient is not fluid responsive. It's probably a false positive, and we will talk about actually why you can see that. So none of these tests, like any of the tests that I've talked about throughout these lectures, is the quote-unquote silver bullet.